So, Mike, the controversy has been three different things when it comes to nipple sparing. Number one, was or is the nipple areolar area involved with a cancer when the patient is newly diagnosed? And the vast majority of the time it's not, and we can usually rule it out by preoperative digital mammograms, ultrasound, and MRI. The next question about preserving the nipple areolar area is, do you have enough blood supply? And we know that if we make our flaps thicker than the traditional Halstedian paper thin, we can keep the blood supply to the nipple areolar area going very, very well in a good 95% of the cases. Angelina had what's called a nipple delay procedure, where they went in through the incision they would eventually use, lift the nipple and areolar area off the underlying glandular tissue to stimulate new blood vessel growth, and then come back several weeks later, 3 weeks or so later, and then take the breast out at that point. The third controversy about nipple sparing is, what are the odds of the cancer coming back in either the nipple or areola? The world literature on this is under 1%, probably in the neighborhood of 0.6%. And one of the fundamental reasons for this is that within the nipple itself, only 12 to 14% of the time are there actually what are called terminal ductal lobular units, where breast cancer arises, actually is in the nipple. Most of these are lactiferous ducts, which cannot give rise to breast cancer. In my own series now of well over 200 of these, I've had one Paget's recurrence in the areola that came 3.5 years later. The biggest series in the world out of Milan, Italy, they've had about 6 or 7 of these, and we haven't figured out how to explain them. And as I've repeatedly said, even with any kind of mastectomy, skin sparing, nipple sparing, no matter what it is, no breast surgeon can remove 1,000% of all microscopic breast tissue. And that's why the percentage is lower down to just a 5% chance or less of developing or dying of breast cancer after preventative mastectomies. It's quite parallel to your story about the peritoneum. And Lisa, the peritoneum is sort of the glad bag that lines the inside of our bellies,
okay,
that Mike is talking about. Hi, I'm Dr. Jay Harness, and I want to share with you important information that I believe that every newly diagnosed patient with breast cancer needs to know.
I'm a breast cancer survivor.
I am a breast cancer survivor.
I am a breast cancer survivor.
And I want every woman to know
about personalized breast cancer treatment
and the genomic test.
A test that helps guide a woman and her doctor
to the best treatment options for her.
Pass it on.